Okay, so guys, let us start with the most, I would say, not very well understood topic of CVS, which is the electrocardiography, and the second chapter of the section 2 of diagnosis of cardiovascular disorders. So the first one was physical examination, second is about ECG, third one will be about non-invasive techniques like echo, CT, MRI, and fourth one will be about some invasive techniques like angiography, etc. Okay, so that will complete our this diagnosis part from the Harrison's textbook of internal medicine. So basically, electrocardiography, ECG or EKG is a graphical representation of heart's electrical activity detected via metal electrodes placed on extremities and chest wall. The signals are amplified and recorded by the electrocardiograph. Okay, utility of ECG, it is a non-invasive, readily available, low-cost, versatile test. The key uses are in detection of arrhythmias, diagnosis of myocardial ischemia, identification of life-threatening metabolic disturbances, like we know, like hyperkalemia, hyponatremia, all these can be seen from ECG itself. Screening for sudden cardiac arrest risk. Electrophysiologic background, there are some sources of currents. What are the sources of current in the body? They are cardiac pacemaker cells, the SA node, AV node, underbranch, okay, and there are specialized conduction tissues and myocardial muscle cells. All these are the sources of currents. What ECG records? It records the depolarization or the stimulation and repolarization or the recovery of atrial myocardium and ventricular myocardium. The sequence of cardiac electrical activation. Firstly, the SA node gets activated. It's the primary pacemaker. It initiates an impulse. Then depolarization spreads through the right and left atria. It causes atrial contraction. Impulse reaches the AV node and the bundle of his on the atrioventricular junction, and the bundle of his bifurcates into right bundle branch and the left bundle branch. The right bundle branch goes to the right side of the heart. Left bundle branch further divides into the left anterior fascicle and the left posterior fascicle. Now, these impulses at the terminal end travel via the Purkinje fibers and supply the ventricular myocardium. The direction and magnitude of depolarization or repolarization, that's what the vectors on ECG represent. Okay, so this is the basic flow of current of the heart, which we mostly know from our previous studies. Now, ECG waveforms and interval. Now comes the important part. Waveforms. The P wave denotes atrial depolarization, QRX complex denotes ventricular depolarization, and STU complex indicates ventricular repolarization. There is something called J point, which was the junction between the end of QRS and the start of ST segment. That's the J point. Atrial repolarization usually not visible. It may be seen in which cases it may be seen in pericarditis, atrial infarction, or AV block. Now, ECG corresponding to the potential phases, effects of electrolyte and drug changes. What can be the effect? Slowed phase 0 in hyperkalemia or faclinide drug therapy. It can result in prolonged QRS. Prolonged phase 2 or 3 of the cardiac cycle can, example, amiodarone hypocalcemia, can result in increased QT interval. Shortened repolarization phase like digoxin hypercalcemia can result in reduced QT interval. Shortened QT syndrome is associated with sudden cardiac arrest. Now, something about the ECG paper and its calibration. The speed of the ECG paper is 25 mm per second. There are big and small squares. The small squares are of 1 mm, and 1 mm distance. If 25 mm is traveled in 1 second, then 1 mm is traveled in 0.04 seconds or 40 milliseconds. The large square is of 5 mm, and 5 mm distance is traveled in 0.2 seconds or 200 milliseconds. The voltage calibration, 1 millivolt corresponds to 10 millimeters of the length, okay, or height, whatever corresponds to it. Now the ECG intervals, QT, there is something called QT correction, okay. There is Bazet's formula. QT, corrected QT interval is QT upon under root of RR interval in seconds. Why it is done? Because QT interval is prone to error in extremes of heart rate, when the heart rate is very less or when the heart rate is very much. हम लोग QT कैलकुलेशन में गड़बड़ कर सकते हैं. So उसे करेक्ट करने के लिए we divided by the square root of RR interval. There's also something called as Framingham formula, in which corrected QT is QT calculated plus 0.154 into bracket 1000 minus RR interval into QT and RR in milliseconds. Okay, so these are just theoretical points. Now, upper normal limits in men, it should be less than equal to 450 milliseconds, and in women should be less than equal to 460 milliseconds. QTC values are not always exact, so these have to be interpreted with caution. Now some information about the ECG leads. We mostly do a 12 lead ECG. They are divided into 6 limb leads and 6 chest leads. 6 limb leads lead to the frontal plane, the vertical. Okay, so 1, 2, 3 and AVR, AVL and AVF. So these are what we connect as clip like structures we connect to right left and right left arm and the left ankle. Okay, and there are 6 chest leads horizontal plane from V1 to V6. Each lead acts like a different camera angle viewing the same cardiac electrical activity. Hexaaxial reference system is there, okay, which results in frontal plane. It is used to determine the mean QRS axis. Lead 1 is at 0 degree, AVF is at 90 degree. Normal QRS axis कहाँ lie करती है? It's very important. It lies between -30 to +90 degrees. -30 से +90 के बीच के इंटरवल में normal QRS axis should lie. If this axis deviates beyond -30, that is left axis deviation -30 to -90 degrees, and if it deviates after +90, that is right axis deviation, which is from +90 to +180. Okay, extreme axis deviation, no man's land, like mostly axis वहाँ तक जाती नहीं है, so that's called no man's land. That's between -90 to +-180. तो ये जो complete 180 degree का angle है, that's no man's land. Okay, now coming to the chest leads, horizontal plane, they are placed as V1, V2 in right pericardium, V3, V4 anterior, and V5, V6 left lateral chest. There can be some extra leads added to the right sided V3R to V6R to check for right ventricular infarction. There can be some posterior leads added V7 to V9 for posterior MI. Okay. So this was all the information about the types of leads and how they are added, and chest leads, limb leads, paper speed, all that. Now coming to the genesis of the normal ECG, second part of the chapter. There is a P wave. It represents atrial depolarization. It originates from the SA node, spreads right to left and downwards, positive in lead 2 and negative in AVR, because they carry different perspectives. Okay. Lead V1 shows biphasic initial positive RA and terminal negative for left atrium. Okay, retrograde P wave is seen in ectopic pacemakers, negative in second, positive in AVR. Okay, so normally it is positive in lead 2 and negative in AVR. Retrograde P wave will show negative in second and positive in AVR. QRS complex represents ventricular depolarization. Okay, it has phase 1 septal depolarization left to right. It is small r in V1, small q in V6. Next comes ventricular depolarization dominated by left ventricle, large S in V1 and tall r in V6. All these are ventricular depolarizations. There is a transition zone point where r is equal to S. हम लोग जब ECG निकालते हैं उसमें 6 रीडिंग्स आती हैं, 1 2 3 4 5 6, and AVR, AVF, all these readings, like 9 or something readings are there, 12 readings. So slowly we see as we go from V1 to V6, it is large S is there in V1 and tall R is there in V6. So as we go from V1 to V6, at some point R and S become equal. So usually in V3 or V4, that's called the transition zone. Next, QRS axis is determined by frontal leads using hexaxial diagram. This axis is influenced by hypertrophy, infarction, conduction blocks. Lastly, the T and U wave. T wave represents ventricular repolarization, normally concordant with QRS direction. And U wave follows the T wave, same polarity, मोस्टली यू वेव विजिबल नहीं होगी, बट इट विल बी प्रोमिनेंट इन ड्रग्स लाइक क्विनिडीन, एम्यूडेरॉन, हाइपोकेलेमिया, risk of torsades. Okay, now, so this was the normal ECG. Now we come to abnormalities of ECG. First being the axis deviation. Normal axis हम लोग बात कर चुके हैं. It lies between -32 plus 90, and left axis deviation can be due to left anterior fascicular block and inferior wall MI and left ventricular hypertrophy. Right axis deviation can be due to right ventricular hypertrophy, lateral MI, dextrocardia, left posterior fascicular block, and can be normal in children or young adults. Extreme axis deviation seen in severe condition or technical errors, like हम अगर आपने लेड ही गलत लगा दी है, सो आपको extreme axis deviation भी मिल सकता है. Okay, so what are the major ECG abnormalities? They can be atrial abnormalities, right atrium overload अगर होगा, so we will see tall peaked P waves in second, third and AVF. We call it P pulmonale. Okay, they can be if right ventricular right atrial overload is there. Next up, left atrial abnormality. It shows broad notched P in limb leads. V1 biphasic P with deep negative component. It's called P mitral because it's on the left side. Ventricular hypertrophy अगर है तो कैसे दिखेगी? Right ventricular hypertrophy V1 will show tall R wave. R wave will be greater than QRS का S. Possibly small q capital R pattern. Okay, RAD, ST depression, T wave inversion in right leads will be seen. If there is left ventricular hypertrophy, S1 in V1, S in V1 and R in V5 or V6 will be more than 35 mm. Okay, RAVL plus SV3 will be more than 20 mm in women and 28 mm in men. It will be associated with left atrial abnormality also, and there will be ST depression and T inversion. Strain pattern can be seen, may evolve into left bundle branch block. Okay, so this was about right atrium, right ventricle, left ventricle. Now they can be bundle branch blocks. How will these manifest? Right bundle branch block will show V1 R, small r capital S R pattern. In V6 we will see broad S wave. Terminal QRS vector will be rightwards and anterior. Okay, because the axis will be deviated. Left bundle branch block L triple B, V1 will be wide QS, in V6 we will see broad monophasic R wave. Loss of septal Q wave will be seen and it's mimicked by RV pacing delayed in left ventricular activation. Now some special patterns can be there. S1 Q3 T3 pattern, it is seen in acute pulmonary embolism. S is seen in wave 1, Q wave and T wave inversion in 3, and often with right atrium defect or right ventricular strain. Low voltage ECG can be seen in COPD, emphysema, can be caused by hyperinflated lungs, diaphragmatic descent. They can be bundle branch blocks. We have talked about it already. But where in which diseases right or left bundle branch blocks can be seen? Right bundle branch block common even in those without structural heart disease. Also seen in congenital, example atrial septal defect, and acquired like ischemic or valvular heart disease. In CRT, cardiac synchronization therapy, this also mimics right bundle branch block with a wide R in AVR. Now left BBB, L triple B, marker of serious underlying heart condition, coronary artery disease हो सकती है, especially with left ventricular dysfunction. There can be hypertensive heart disease. There can be aortic valve disease, which can include posterior TAVR, and there can be cardiomyopathy. Okay, this can be associated with increased CV morbidity or mortality. So basically, what all about ECG is there? It may be chronic, intermittent, or rate related. It can cause secondary ST or T changes. T wave usually opposite to terminal QRS deflection. And it differs from primary repolarization abnormalities due to ischemia, electrolytes, or drugs like digitalis. Now some fascicular or hemi blocks in the left and right, left anterior and left posterior bundles. Okay, so they do not significantly prolong the QRS. Left anterior fascicular block is common, and left axis deviation less than for minus 45 degrees. Left posterior fascicular block LPFB is rare, and right axis deviation is seen more than 110 degree. There are some mimics of bundle branch blocks. We have to rule them out before classifying the disease as bundle branch block. There are hyperkalemia, antiarrhythmic drugs class 1, TCAs, phenothiazines. Pre-excitation syndromes like WPW may also cause QRS widening. Okay, so this was about the abnormalities of the ECG. And now we come to the disease part. Okay. In myocardial ischemia and infarction, what we will see in ECG in acute ischemia, ischemia alters the membrane potential and AP duration, creating injury currents. ST changes होते हैं जिनकी वजह से transmural ischemia. This shows as ST elevation and hyperacute T waves. Subendocardial ischemia shows as ST depression with ST elevation in AVR. Okay, next up ST elevation in MI. ST elevation in specific leads indicates infarct location. Anterior wall LED V1 to V6 first and AVL. Okay, and inferior wall RCA it will show in second, third, and AVF. Posterior wall reciprocal ST depression in V1 to V3, or if we do V7 to V9, it can show actual elevation. Right ventricle ST elevation in right sided leads. Now, how will MI evolve? ST elevation will be there, then T wave inversion will be there, and then Q waves will be there. These Q waves do not correspond to transmural infarct exclusively. They can also occur in subendocardial infarcts also. Okay, now reversible ischemia अगर है तो example Prince metals angina, there can be transient ST elevation without Q waves. इसके अंदर हमें कुछ स्पेशल पैटर्न्स भी देखने को मिल सकते हैं. डीप टी इन्वर्जन्स इन V1 to V4 फर्स्ट एंड AVL, दी सजेस्ट क्रिटिकल लेफ्ट एंटीरियर LED stenosis. Okay, and persistent ST elevation post MI suggest wall motion abnormality or aneurysm. What are the limitations of this? Normal ECG does not rule out MI, and ST or T changes can also be masked by left bundle branch block, pacemaker, WPW syndrome. And this ST elevation, it does not only indicate towards MI, it also indicates towards pericarditis, myocarditis, including COVID-19 infection, myocarditis, early repolarization, Takotsubo syndrome, and electrolyte disturbances like digoxin, etc. Okay, next up metabolic and drug induced ECG changes. Hyperkalemia में क्या होगा? There will be peak T waves, we call them tall tented T waves. Progression, decreased P wave amplitude, AV block widens QRS, sine wave, and the patient gets into cardiac arrest. Okay, and what are the other mimics of ischemic changes? There can be ST depression, like in digoxin, LVH, hypokalemia. There can be T wave inversion in LVH, cardiomyopathy, myocarditis, Takotsubo, intracranial bleeds, and cardiac memory defect can be effect can be there. T wave changes following wide QRS rhythms. Okay, now some metabolic and drug induced ECG changes we have talked it about, right? Hyperkalemia, progressive ECG findings, peaked or tented T waves, decreased P wave amplitude, eventual disappearance of this, pident QRS, sine wave pattern. It can result in asystole pattern, and this is a medical emergency. Hyperkalemia is a medical emergency. Hypokalemia can also be there. Hypokalemia represents with prolonged repolarization, often with prominent U waves. QT interval may appear prolonged. Risk of torsades de pointes is there. Now QT prolongation caused by drugs that prolong the ventricular action potential. Class 1A antiarrhythmics like quinidine, procainamide, disopanamide. Class 3rd agents like amiodarone, dofilitide, sotalol, ibutylide, and others like tricyclic antidepressants, phenothiazines, All these can cause QT prolongation, which we call as torsades de pointes. ओके हाइपोथर्मिया हम लोग पढ़ते हैं राइट एंटी एरिथमिक्स ड्रग्स के साइड इफेक्ट्स में टॉर्सिडीज डी पॉइंटर्स मोस्ट कॉमन इन क्लास वन ड्रग्स hypothermia Osborne J waves. Okay, hypothermia temperature is going very down. Then Osborne J waves, convex elevation at the J point. What was J point? After QRS complex and T wave, the mid junction between these two is called the J point. QRS and QT prolongation may coexist. If there is some intracranial hemorrhage, like subarachnoid hemorrhage, deep wide T wave inversions, severe T wave pattern is seen, and QT prolongation can also be seen. In calcium disorders, there is hypocalcemia. If in hypocalcemia, there are prolonged QT intervals due to prolonged ST segment, and in hypercalcemia, there are shortened QT intervals due to shortened ST segment. Effect of digitalis, it shortens the QT interval. Digitalis is a drug which is given when the heart is failing. Okay, so it shortens the QT interval, and scooped STT complex reverse check mark appearances there. Now some non-specific STT changes and low QRS voltage. Non-specific changes, T wave flattening or minimal inversion. Mild ST depression can be there. This is seen in electrolyte or acid-based disturbances, CNS infections, endocrine disorders, drugs, ischemia, hypoxia, and it can also be in even physiological states like posture, meals, etc. Low QRS voltage defined as an QRS amplitude less than 5 mm in limb leads or less than 10 mm in precordial leads. It is seen in pericardial or pleural effusion, in COPD, in infiltrative cardiomyopathies like amyloidosis, and in anasarca. Now, electrical alterance definition. What is electrical alterance? Beat to beat variation in ECG waveforms is electrical alterance. Total electrical alterance P, QRS and T plus sinus tachycardia highly suggestive of cardiac tamponade. बीट टू बीट वेरिएशन भी है और साइनस टेकिकार्डिया भी है. इट्स सजेस्टिव ऑफ कार्डियक टेम्पोनाड. STT or U wave alterance indicates electrical instability and may precede ventricular tachyarrhythmias. Now this was all about the basics of ECG, the paper speed, the abnormalities of ECG, and the disease specific abnormalities of ECG. Now we come to the clinical ECG interpretation. There is a 14-point system. Standardization and technical quality, lead placement or artifacts should be there. Next up, rhythm should be checked, heart rate has to be checked, PR interval or AV conduction has to be checked, QRS duration has to be checked, QT upon QTC interval should be seen, mean QRS axis has to be seen, P wave morphology, QRS voltages, precordial R wave progression, abnormal Q waves, ST segment, T waves, and U wave. All these have to be seen. Always compare with prior ECGs for accurate assessment, and computerized ECG interpretation is useful for storage and retrieval. What are the limitations? Still prone to errors. Okay, must always be reviewed by a trained clinician. Like computer ने ECG generate करी and it's giving the results. So we as the clinician should also look into it, that whether there is any discrepancy or the result is accurate. Now differential diagnosis of ST elevation दिए हुए हैं. We have discussed them already. Ischemia or infarction like STEMI or Prinzmetal ischemia, tacos buco cardiomyopathy, post MR aneurysm, pericarditis, early repolarization, left ventricular hypertrophy, left bundle branch block, pulmonary embolism, Brugada syndrome, drug effects like class 1C and cardioversion, electrolyte disturbances, hyperkalemia, hypercalcemia, hypothermia, Osborne waves are seen, myocarditis, tumors, and trauma. All these can mimic ST elevation. Okay, so we'll see the figures. We'll after we complete this second section, we'll also make a video covering all the diagrams of the diagnosis part. Okay, so we'll see them also. Meanwhile, let us see a table. So this is a table about important ECG intervals. The RR interval is the time between two R waves. It's used to calculate the heart rate, and it can vary. Okay. There is PR interval, atrial to ventricular depolarization time. It is almost 120 to 200 milliseconds. The QRS complex time is the ventricular depolarization duration. It normally should be less than 100 to 110 milliseconds. The QT upon QTC time, total time for ventricular depolarization plus repolarization, it is also very. Now, the comparison is there between the action potential phase and the representation of that in ECG. Like cardiac कार्डियोमायोसाइट में जो एक्शन पोटेंशियल रन कर रहा है वो ईसीजी में कैसे रिप्रेजेंट हो रहा है. Phase 0 and sodium influx at the start of QRS complex. Phase 2 is represented as plateau phase. There is ST segment which is isoelectric segment, and phase 3 the repolarization time is represented as T wave. Okay, so this completes our topic of ECG. Basic, very, very basic part. Like if we revise this often and also read the chapter from book, we'll get more or less a crude idea of whatever basic points we have to consider while looking at an ECG, and we do not get lost as soon as we get an ECG in our hands. Okay, so this completes the second part of the diagnosis. Next up, we'll be covering the non-invasive techniques of echo and CT, MRI, etc. Okay, so like, share, subscribe. Thanks for watching.